hi everybody. Thank you so much for inviting me and having me. I'm really excited to be here and really admire all the work happening in the centre. So it's lovely to be part of it in some way. So as Christy said, I've recently moved from London and haven't yet fully got an Australian accent. I think you'll probably agree. And what I did when I came was I kind of brought the research program that I have been developing with me, and I'm trying to manage time zones of between Australia and Africa and continuing much of that work as well, kind of extending the work I'm doing into Southeast Asia. And my area is adolescent sexual and reproductive health, and I've been working predominantly with young people growing up with HIV in Africa, the UK and the US since about 2010. And most of my work is, or a considerable amount of my work is qualitative research embedded within large international clinical trials. So I am very used to being one of very few social scientists in a big group explaining why what the young people say is really important to understand how interventions are being used. But what I'm going to be talking about today is a slightly easier system, which is just a qualitative set of studies which isn't embedded within a clinical trial, which is looking at the experience of growing up in a high HIV risk environment. So it's both those who are already infected, either because they were born with HIV or they've acquired it horizontally, as well as those whose status we don't know. So what we're looking at in this combination of studies, which I'll go into talk on a bit more detail about the actual nature of the studies, is we're looking at substance use and how that's fueling or reshaping HIV risk for young people in sub-Saharan Africa. So what we know that there is an increasing problem with this, but we know actually surprisingly little about how young people become involved in substance use in sub-Saharan Africa, what it looks like, what they're taking, and what the impacts and effects are, and also how this interacts with existing stigmas around HIV and other stigmas, and what the implications are for intervention. So that's going to be kind of the structure of my talk today in terms of trying to address some of these questions. So I've been really interested to learn more about the epidemiological situation for HIV in Australia since I've been here, and how much optimistic talk there is about the possibility of eliminating HIV. And of course, I understand that lots of people are very cautious about that, but it does seem to be that the kind of rhetoric and the discourse is moving towards the technical feasibility of that. And I guess the context in which we're working in terms of South Africa and Uganda are very different. And I think although the global discussion continues to kind of emphasize the possibility of elimination, the kind of formidable nature of the challenges, particularly as it relates to adolescents in Southern Africa, kind of makes it seem a slightly less plausible plan, unfortunately. And to put that into context, in many parts of sub-Saharan Africa, as you know, there continues to be overwhelming incidence and prevalence rates. So for example, in KwaZulu-Natal, which is where we're working in South Africa, amongst 15 to 49-year-olds, the prevalence rate is about 18%. That's 22% for women of that age category. And as many as 7,000 new infections a week are occurring amongst adolescent girls and young women in Eastern and Southern Africa, and 2,000 of these infections a week are happening in South Africa alone. So that the extent of the problem is extraordinary, given how long we've known about it and how much effort and input has been put into it. And there's also been a great deal of focus for some time on the adolescent girl, and that's only really belatedly happening to focus on adolescent boys, and this is quite a significant part of the problem and needs to be redressed. But one of the reasons that adolescent girl has garnered so much attention is because of the extraordinary high incidence rates amongst that age group, and also trying to work out the kind of cycle of infection in South Africa. So this is some work that's been done at what used to be called the Africa Centre, which is in KwaZulu-Natal, now called the Africa Health Research Institute, which looks at the kind of cycle of infection in terms of age-disparate relationships and older men having sex with younger girls, adolescent girls, who then infect, and then the women in their mid-20s. So kind of how the cycle works and what might be driving this enormous incidence amongst adolescent women. So there's a considerable amount of work being done on age-disparate sexual partnerships and how to reduce the risks of adolescent girls and young women. But given that their biological, structural and social vulnerabilities all converge to place them at significant risk, it's increasingly urgent to understand the context of youth behaviour and to demonstrate solutions that will support their protection. And much of the emerging evidence suggests that substance use is a factor within this. So what we do know in some of these contexts is that there are exceptionally high rates of unemployment, and that contributes to enormous internal migration and the kind of thriving informal economy where people are working very, very casual labour if they have anything at all. There's also high use of alcohol, which is normally sold in sachets, and a lot of use of substances, and the kind of primary ones that are being used are cat, crystal meth, and wonga. And wonga is like a terrifying combination of things, including rat poison and antiretroviral treatment. It's kind of, so wonga is basically a fixed label, and what goes into it changes considerably. So as I said, there are very high HIV prevalence rates, as you know, but it's still kind of really staggering, I think, to hear the numbers. And there's increasing work talking about the causal relationship between alcohol and HIV incidence and reinfection. But we still know very little about how young people living with HIV specifically engage with substances, and what are the effects on young people who have migrated. So they're moving from rural areas, for example, to peri-urban settings, as well as to the big cities, and how that affects their management strategies for harm reduction, for social networks, and generally their awareness of harm reduction strategies. Do they identify themselves as at risk, and what can be done about that? So what I'm going to be talking about is drawing on two reasonably large qualitative studies. The first one, which we've completed, was focusing on growing up in a high HIV risk environment, and we did that in Uganda in 3 sites. And then we did that with young people and caregivers. And then the second study I'm going to be focusing on is a current one, which we started in the middle of this year, which is called Finding Your Feet. And that's looking at this experience of internal migration. And this is in Uganda and South Africa, and with young people. I'll go on just to explain both of those in a bit more detail. So the first study, which we completed around growing up in a high HIV risk environment, we did conducted in 3 parts of Uganda, in Kampala, the capital, or ostensibly the capital, even though it's not. It's the biggest city. Mbarara and Kalungu. And Kalungu is a much more kind of rural, peri-urban area. And we spoke with 60 young people aged 12 to 24, 45 of whom we recruited from HIV clinics who were HIV positive. And the other 15, we didn't know their status. And then we asked them to nominate a significant other in their lives that could help us understand their experiences. So we spoke with 30 caregivers. In some cases, they were biological parents. In most of the cases, they weren't, and that reflects the fact that orphaning is an extremely strong characteristic of this age group, so the parents are no longer around. And we conducted a study with a longitudinal design, and all our work with adolescents actually adopts that approach, which is a longitudinal design of repeat waves of data collection. And one of the reasons that we do that is because this is an intensely difficult area for people to talk about, and we've learned how silenced, we all obviously understand it's likely to be silenced, but with young people that's particularly acute. And that's also acute around how much voice a young person has anyway. So if you're thinking about trying to understand what's happening in the clinic, or if you're thinking about substance use or sex, it's the kind of the most silenced of the silence. So it doesn't necessarily make sense for us to try to do qualitative research where we only speak with the young person once. So we also find really interesting changes between the first phase in terms of the data that we collect, and then how radically the story changes as we conduct further interviews with them. And a lot of them will reflect on why they withheld information or kind of characterize their experiences quite differently. In the first interview, they'll be very candid about why they were doing that. So that's the approach that we've always taken. So I haven't pictorially displayed this very well, but the concept is that that every phase informed the next phase. So we were doing iterative data collection and analysis in real time in order to ensure that the topic guide for the subsequent phase was informed by what we had already learned. And I want to return to that in a minute because it's not totally straightforward. One of the things that we did by including the caregivers was this kind of sense of trying to understand the inherent relational nature of the challenges that young people are facing, so that the adults looking after them will have a significant influence over their healthcare decisions, their opportunities to participate in research, and what they come to know and understand about the condition that they're living with. So we always start with the young person, but we understand the kind of relational context and the kind of constraints on their relational agency. So we try to incorporate the significant others and let the young person choose who that might be. The second study that we are working on currently, which is around recent young migrants to peri-urban settings, so we're looking at kind of the nature of HIV risk, the fluid mobile populations, whereas the previous study it didn't have the same focus on that fluidity and that dynamism of movement. So we're doing this study with 100 young people, 50 in Uganda and 50 in rural KwaZulu-Natal, who are 16 to 24 years old. And out of those 50 in each site, we're recruiting 10 who haven't moved, so the people that are still in rural areas, because we're really interested in terms of what that does in terms of social capital, aspiration, and how that might affect kind of economic opportunities, and how that also relates to substance use and HIV risk. So interestingly, so the prevalence rates are pretty high, given that we're talking about 15 to 19-year-olds. The Lukaya data we're particularly skeptical of. It doesn't make sense that it's so low. So that is also to do with how they're collecting the data, how many people are in, how people are engaging in testing, etc. So we're pretty skeptical about that. In terms of how we're sampling people, it's ostensibly purposive and ideally theoretical as it goes on, but in reality it's just talking with anybody who's happy to talk to us. In South Africa that's particularly difficult in these communities. We're really struggling with that. And interestingly, in Lukaya, people are very keen to talk to us, and we're not having any problems with recruitment. We've recruited really fast. And the stories in southern Uganda, so Lukaya is a fishing town, incredibly high adult prevalence rates, and it's kind of always been, since we've understood anything about the epidemic, we've always thought that these are kind of very, very high clusters. And we're finding a lot about exploitation of young people. A lot of people, a very, very high prevalence of substance use. So in some ways, it's surprising that it's there where they're particularly keen to talk to us, but that's the way that it's working. And the other thing that is also quite different between the two sites in terms of our approach is that in Uganda, we've been able to leverage the emancipated minors ruling on consent. So for 16 and 17-year-olds, we're not required to get adult or guardian consent, because if you can demonstrate that they are providing for themselves economically, and they therefore qualify as an emancipated minor, you can you can circumnavigate needing adult consent. And as you can imagine, for this study, that's really, really important, because by definition, the parents are nowhere near. They've left home. So that's working really well, and we're quite constrained by that in South Africa because it has to be 18 plus, and we really want to get the younger age range. And it's also why we don't have a relational component of this. We don't have the significant others because they're just not around, and so that's why we're taking a slightly different approach with this one. So just to give you a little bit of the study design of this, we have started off in each site doing an observational formative phase, which I guess is just, I know that you should probably never put these two words together of rapid and ethnography. It's a contradiction. But essentially, we're there for a month in the community. I say we, not me, sadly for me, but usefully for the study. Otherwise, if there was a white person walking around, it would definitely be disruptive. So we're spending 4 weeks or so in the community, looking at where young people are going, where they're spending time, talking to as many people as possible to inform our sampling approach and our topic guides for the series of interviews that we're conducting. And we're going to keep the data manageable, we're going to reduce down our sample size from 50 to 30 for the second phase, and then to a kind of a very much a theoretically informed group in terms of how we select the smallest sample of 10, where we'll ask them to keep audio diaries for a month, and then we'll have a series of workshops with them to discuss our emerging findings and to collaboratively design interventions or consider ideas that might be kind of palatable, accessible, acceptable, and hopefully deliverable, so that when we produce our findings, we've got a series of different sorts of findings, including what young people consider might be useful in this setting. And I have to apologise because at least one person in this room has heard this presentation before at the AIDS Impact Conference in Cape Town. And one of the pieces of feedback that I was given, because I had lots of questions about methodology in that presentation, was to talk a little bit about our interview summaries approach. So I've obliged, so that's what this bit's about, is that we've mentioned how much we're doing longitudinal research with pretty serious volumes of qualitative data, and how we manage it, given in order for it to be effective, it has to have been analysed before we move forward, and we're doing this obviously in a relatively short time frame. Because although we're interested in capturing change over time, what we're really interested in is the quality of the data and building the trust. So we are still trying to do that in a relatively, I guess, concertinaed amount of time in order to move beyond the standardised scripts is the rationale for the longitudinal design. So what we have found across a number of studies is the major challenges, I'm sure is pertinent to lots of you, with how you manage transcription, particularly if you then need to incorporate translation and you have a rapid turnaround, and how do you manage that? So one of the things that we have been doing is, I guess we've kind of been returning to what used to be done a lot more, which was we audio record all our interviews, all our data, but we don't transcribe them. We write really detailed interview summaries whilst listening to the audio recording, and we integrate the field notes and the kind of summary of the interview. And it means that by listening to the audio recording whilst doing it, a lot of the details, so the person who did the interview is doing the summary, and they're having their memory kind of jogged by listening to it, but they try and do it within 2 or 3 days of the interview. And then we also are able to kind of selectively transcribe data verbatim that seems really obviously pertinent at the time, but of course we can revisit it if we need to. So these interview summaries might be 10 to 15 pages of complete, dense prose, including observation, under quite a specific structure. And so that could then be got back to the team within 3 or 4 days of the interview. So we can kind of keep on top of what we're finding. And we always have the opportunity to go back and transcribe and translate, but just the translation aspect of it really is a time lag problem. There is, of course, the fact that you're translating like whilst you're writing. So it's not necessarily suggesting that this doesn't have its own flaws, but it's meant that the longitudinal design is operationalizable, that we can actually do what we need to do with it, and then we can always revisit it if we need to. And we've published using this approach, and I think we were a little bit apprehensive as to, I mean, it worked for us, but whether it was going to impede us being published, but we've been publishing using that approach, and we're also working on a paper just to kind of outline the method. And it's not necessarily particularly complicated, but it has revolutionized for us being able to kind of deliver on these kinds of studies and conduct iterative data collection and analysis effectively. So to the findings. If we first of all focus on adolescents living with HIV before moving on to talk about adolescents more generally. So in terms of adolescents living with HIV and their interaction with their experience of substance use, one of the key things that they talk about is in the clinic, it's set up as an absolute stark binary, that good patients will never engage in any form of substance use. Only bad patients will. That the clinical messaging is all about the fact it will render the ARTs ineffective, and it would be a really appalling thing to do. And so there's this sense that the young people can report, not necessarily based on scientific evidence, but just the major implications of drinking or taking drugs whilst on ART. And this produces major problems for young people. So the first one is that there's actually they're juggling social harms all the time as well as the physical ones. And there's major risks in abstaining. If they're with their peer groups and they're always not drinking, for example, they're concerned about all the questions that will provoke. Like how does that work if everyone else is? And they're worried about the deductive disclosure that comes from that. But they're also, if they do drink, of course, they're concerned about the interactions with their treatment. And what we've learned from this and from other research is that we learned that young people then don't take their treatment when they're going to be drinking. So they might not take their treatment at weekends because of this message. And one of the reasons that's kind of given for why they might not be taking their treatment if they're drinking or taking drugs is because they're forgetting, because they're drunk, and so they don't care or they don't notice. And of course, that could be happening. But what we're finding, it's unlikely that's going to be the only factor at play, that they're missing treatment, and there may be many factors coalescing to make adherence difficult to maintain. And so it kind of gets to a number of issues that affect adolescents living with HIV in these contexts. The first one, which was touched upon by young people and their caregivers, is that drinking and taking drugs might not only be a social activity, which is important to engaging in peer networks and the fabric of their social life, but it also might reflect some mental health challenges that they're going through, that they're having an incredibly tough time with the secret that they're carrying, and this may be a way of managing their secret and kind of escaping as a release or relief. And so the fact that they can't ever talk about that in the clinic not only means they can't get more accurate information, that they are having to have a very kind of economized account of what's going on, but also it means that it makes it much harder to kind of reach out for mental health or psychosocial support. And so it's another thing that young people learn not to talk about with their healthcare workers. They learn because of this binary that people aren't going to be receptive to talking about it, and it demonstrates the lack of, or the challenge that the clinical care system has in engaging with the social realities of young people's lives. That this is not necessarily a totally sustainable approach, and there's real challenges for retention, so that young people know that if you get pregnant, it's going to be really difficult to come back to the clinic because you were told not to have sex. And if you are drinking or taking drugs and that gets found out, it's really difficult to come back to the clinic because you were told not to do that. So it's real challenges, even if they are retained in care, but also as a potential risk factor for losing them out of care. And then moving on to young people more generally, when we look across our studies and the context in which we're learning about, we found that in these sites, which were generally peri-urban, kind of small, informal towns, and also in rural areas, there appears to be a pretty high rate of substance use, including alcohol among young people. So, for example, a couple of weeks ago when I was there, we were chatting as a team about how common it was now to see young people openly smoking marijuana on the streets, and kind of just the shift in terms of how that is no longer kind of socially policed in the way that it might have been previously. And of course, it's difficult to know how much this is definitively changing or increasing, but certainly it's talked about as there having been a substantial shift. In Uganda, where we're working, there's a general population cohort that we're working within the same area, and that data has been collected for, I think, around 28 years. So we could try and look back at a historical analysis. It depends if people were asking those kinds of questions at the beginning. But the key story that we're learning is that substance use is heavily entrenched as a consequence of low employment, poor economic and educational opportunities, and so in part it becomes about diversion, entertainment, and peer pressure. And so substance use in part reflects a kind of discounting of future, an investment in the pleasure of now. And many young people explain that they engaged in it, or that others engaged in it, as a way of escaping. In fact, this 18-year-old man talks about, he thinks some of them may be trying to saving their lives or forgetting their problems. And it reflects a much broader trend, which is about how within this economic and epidemiological context, the future can look pretty bleak for young people, and how it inhibits hope and how that affects behaviour. So in emphasising the immediacy of relief and pleasure that came from substance use, it raises the question that if the context dissuades them from anticipating a better future, then it also undermines the rationale to exercise safer and more protective behaviour. So critically, in all the sites that we're working in, there appears to be a circulating community narrative that young people who use substance users are all or will become HIV positive as a result. So there's, in the way people talk about it, they've become quite enmeshed for young people. So here he talks about through having sex with any one of those they meet, they acquire AIDS. The alcohol is the most way of spreading AIDS because they can't remember about condoms. And this is an example of an interview summary, so it's reported speech rather than kind of a direct verbatim quote. So one of the key reasons for this is that substance use is presumed to lead inevitably to unprotected sex, and very commonly transactional sex. And within these environments, that is assumed to lead to HIV infection. So such is the entanglement between substance use and HIV that there's an assumption described by many young people that anyone who is HIV positive and young must have engaged in substance use and unprotected sex to have got HIV. So they caught HIV through adolescent behaviour, and there was very little awareness, for example, of perinatal infection, and so most young people were supposed to have engaged in these practices. And although drug use appears to be taken up by more by young men, young women are also entrenched within the risks of this. And there are many reports, at least in the data, of young women becoming drunk and then being put in a very vulnerable situation. And because of this presumed connection between substance use and HIV, there's an additional layer of blaming. However, there's much more going on, and unsurprisingly, it's not just about intoxication. And a key element to return to is that the HIV risk experience for young people, as I said, is framed by a paucity of education and employment opportunities, which are stifled by the ongoing economic conditions. And so in the context of scarce income opportunities, many situations that young people find themselves in, and young women in particular, are to derive implicit financial survival. So young people talked about, by being in the bar, by stepping over the threshold into somewhere like this, and having a drink bought for them, and they were implicitly agreeing to have sex with a person who bought that drink for them. And if, for example, tends to be an older man, bought a drink for a group of young women, then they would have to discuss who was going to be the woman who was going to sleep with that man, because that was the deal. And so it's about stepping over to the threshold into the bar that kind of escalates the HIV risk. And there may well be some girls who go into a bar who are naive to these social expectations, but the majority are aware of this. The majority of the young people and the young women talked about this and knowing about this. And that it can be a means to instigate or build a relationship which conveys various social and material advantages. So it's not just about getting a drink bought for them for that night, it's about where it might lead that could be valuable to them. And just want to take a moment, because the term transactional sex is a very complex one. Relationships can be about love, and often a really important element. So I don't want to be reductive about describing these relationships as purely transactional and other relationships as not having a transactional component in it. So it's not absolutely distinct from what might be common anywhere in the world in which love and relationships operate to varying degrees as transactional. But I really appreciate the work that was done by the Strive group, which are based at the London School, that was published last year in the Social Science and Medicine journal, that delineates the prominent paradigms in the literature and about what constitutes transactional sex. Sorry, it's really tricky to read, but the kind of core elements that they're talking about is sex for basic needs, sex for improved social status, and sex and material expressions of love. So those are the three kind of prominent paradigms. And they also frame this as being represented through three continua, which are deprivation, agency, and instrumentality, which convey the nuance, complexity, and ambiguity that characterizes the motivations and meaning conveyed in transactions across these contexts. So what I'm talking about in these bars is a particular kind of love that these young women might not otherwise want. So within our data, there are a broad range of examples of the subtle through to the obvious experiences in which young people are engaging in sex for material transactions. And the key thing is that the conditions in which they are then having sex are heavily constrained in how much then they're able to negotiate to do that safely for them. And it's commonly unprotected by condoms, which puts them at risk. So it's about how to reduce the harm of these interactions rather than necessarily to be focusing on the relationships themselves. It's about the harm that comes from those interactions. So the key points I want to emphasize is that this is all taking place within a heightened, generalized use of substances for young people. And this isn't extreme. This isn't something that's pushed to the side. This is an increasingly explicit and overt part of the fabric of daily life. And that, as a result, the gendered social practices carry kind of additional risks. And so to kind of wrap up, there are very strong characteristics of youth and young women in particular who are engaged in risky behavior, which is that they will be engaged in substance use, they'll be having unprotected sex, and that will lead to HIV acquisition. And so these are all heavily entangled in this discourse of risky youth. And so to be HIV positive in these contexts now is increasingly to be presumed to also have used alcohol or substances. So it moves them from being at risk to being risky. And so any kind of presumed, there's a presumed volition to this rather than around a reflection of structural vulnerability, which concretizes and adjusts existing stigma. So the addition of substance use kind kind of adds another rung on a social hierarchy ladder in which young people living with HIV are foolish and reckless beyond what might be ascribed to an adult who's HIV positive. And also, interestingly, beyond what might be ascribed to an adult who is engaging in drinking or substance use, as though somehow the young people have done it with less competence and therefore have had these implications and therefore are more at fault. So the other thing was that young people spoke about substance use being as a consequence of hanging out with other young people. So we've written elsewhere about adolescence being defined as a behavioural category rather than a life course stage, and that behavioural category is identified by transgressive behaviour such as substance use. So adolescence is something that's done or performed. And interestingly, within this social framing of it, it's also something that can be caught from peers. So adolescence as a concept or as a behaviour is infectious. And so as a result, we've found a lot of the time in our accounts, and it's interesting how that might adjust in a second study as we go through phase 2 and phase 3, as to there's a lot of this isn't happening to me. This isn't me, I'm just telling you about what's going on for other young people. But I think that is really interesting in terms of we think about implications for interventions, which is that they're not wanting to identify as being these risky adolescents. There's a lot of rhetorical, social, physical distancing work that they're trying to do. So if you set up an intervention for adolescents, are they going to want to come because of all the meanings that are imbued within that? And so just to conclude, I guess the first point is the kind of strengthening the capacity of the HIV treatment and care system to engage with the realities of adolescence, and that's something that's kind of woefully absent at the moment, and understandable, but does need to kind of move forward if we're going to retain people and we're going to ensure their well-being. And that HIV prevention increasingly in these contexts needs to engage in harm reduction of substance use and risky sex. But if you start calling it that, no one's ever going to want to come along. And thinking about what alternatives there are for young people in relation to substance use and engage in structural interventions which engage in positive present and future, which is essentially going to have to be around the youth economy. And then finally, if one of the things that we're learning around substance use is that this relates to discounting the future, what disruptive impact is this going to be having on some of the kind of really golden HIV prevention, kind of biological technologies, medical technologies that are being put forward to resolve this issue, which is treatment as prevention and PrEP. And if it's targeted at adolescents, but we understand that this is the landscape or the topography of adolescents' experience, how disruptive or how much are they going to clash? Thanks very much for your attention.
Was it messy, overtly intoxicated substance use? Obviously, alcohol has been around in communities for a very long time. So was adolescence, as in relation to alcohol, seen as a category, or has it emerged with HIV or with the other substances that might be emerging?
Yeah, I think it absolutely. So the first point is, of course, none of this is necessarily radically different to how it's been. But the way people characterized it is that younger and younger girls are engaging in alcohol younger than they're used to, and that there's far less kind of community surveillance around young people going into bars. So it's not necessarily, we can't be sure that the behavior has changed, but it's become more overt. And then the implications of that behavior have become potentially more risky. And then they do talk about being intoxicated and it being messy on many of these substances. And the way they talk about it in quite a gendered way. So Wunga and Tick and meth is considered to be kind of a young man's substance. But then it's about how young women kind of become embroiled in it in terms of the community narrative. So it's not necessarily about change, but there does seem to be a shift both in terms of the risks of doing so and in terms of the fact that it's more overt, more explicit and less policed. It's more accepted. And it is really difficult with the caregiver data because you can imagine these narratives have been going on forever. You know, these young people, it's crazy, they're being awful. And no one's suggesting that is exceptional. But people are talking about it kind of increasing. Everybody's talking about it increasing, and certainly all the research teams that we're working with say you see stuff now that you just didn't see before. So it's not, we don't know if the behaviour is changing, but it's certainly more open. Does that answer your question?
Yes. Thanks very much for that. I'm really interested in young women talking about their own personal alcohol or substance use.
Yeah.
Having done some work in South Africa with young women, it's so often that they talk about what others are doing. I just worked on a project giving young women a cash transfer, and one of our concerns was we're going to give women cash. What is this cash going to be used for? And almost no one reports using it for alcohol or for substances. There's almost no negative use. And I'm just interested in how much you found in these cohorts that you're following that young women talk about their own alcohol use or substance use rather than others, because my experience is girls in particular don't talk about their own alcohol use.
Yeah. So just to try to summarise and repeat that question while I remember. So it's about how much young women talk about their own substance use, and that is quite rare in research that you've done. So I guess there are two things. The first one is that young women similarly talk about what happens to other young women, but they never talk about young women ever having to purchase the alcohol or substance use. So I guess that might be something that's happening in what you're finding. And the second thing is where young women are talking about it explicitly is when they're talking about transactional sex. And within the kind of broader caveats that I place transactional sex in, that they would drink or take something in order to manage that experience. So that's what makes it bearable, is that they would drink. So there are people who are in our study who would kind of identify as being commercial sex workers, and then the majority identify as engaging in sex to get by for different reasons in different contexts, and that's when they talk about their own substance use. When we've heard about women, what happens in a bar, everybody says it. Everyone tells us a story, but we haven't yet had anybody in the first two phases, the formative and the first phase of the interview, talk about this is what happened to me. But they all talk about expecting in any relationship to have material resources, including substances. And the young men talk about at times they go without meals in order to make sure that their 3 girlfriends each get a gift. So they will go hungry to do that because otherwise they'd lose their girlfriends. So it's there, but done in more kind of subtle ways.
Any other questions?
Hi.
I'd like to know a bit more about the longitudinal design first study. Just things like how many times we put what sort of activities that researchers undertook to build trust happening for participants, lessons learned from that.
Yeah, so this is the question is about the kind of methodological approach, or kind of way that, given we had a longitudinal design to build trust, what did we do to kind of manage that? Well, for example, the young people that we spoke to who are based in a clinic, the first interview, I think they were pretty surprised because it was asking questions and having time in a way that their clinic experience, because of the enormous burden of care that all the healthcare staff are under, they can't normally devote to an individual. So the first interview, they were generally just quite surprised about the whole thing. And we tried to use, for example, emotion cards to help them identify complex feelings when they weren't at all used to talking in that way. And because we were interviewing down to 11 or 12, so for example, asking them how they felt about treatment, and how they felt when they were holding their ART in their hands, they would say, one person, for example, said, I think, that they were hopeful, that they were scared, that they were disgusted, and they were tired. So they were hopeful because, if they live long enough, there might be a cure. And they were scared because it's a reminder they have HIV. They were disgusted because it gets stuck in their throat and makes them retch. And they were anticipating that before they took it. And they were tired because this happens all the time, and why do I have to keep on taking it? So there are ways that we just try to kind of utilize the tools to enrich their capacity or their willingness to talk. And then in the second and third interviews, we found that it was really important, particularly those within the clinic, that everything that they had told us had not got back to anybody. There was no seepage or leakage of their stories in their account. And that, across all our studies, has played an enormous role in building trust. They talk about how there's no story that is theirs, that they share with somebody that doesn't then become everybody's story. So that was a really important part of it. And the third part of it is to do with the value that we placed on it. And that is difficult because it makes it sound like it's a comparison, but it's simply that in the clinics or elsewhere, people are under enormous time pressure. So it's a luxury and a privilege as a researcher if you've got the time to tell the young person you've got all the time and you'll listen to anything they want to tell you. And so I think that when you keep on doing that and you remember what they said and you're interested in what they're doing, the context, the paucity of opportunity for that makes an enormous difference.
I think we need to move on, but please stay also for the end of the session. We're going to have some drinks and meals outside, and that's a chance to ask Sarah some more questions directly. So please join me in thanking Sarah again. Jessica Botfield, who is Senior Research Officer at New South Wales. She's a sexual reproductive health nurse by background, and is also a research assistant here at our centre, and is talking about her doctoral research, which is happening through the School of Social Sciences here at UNSW.
Thank you. Hi everyone. So I'm presenting today just a brief overview of my doctoral research, which is looking at young people from migrant and refugee backgrounds and how they engage with and access information and care regarding sexual and reproductive health. So at this stage, I finished recruitment and analysis, and I'm writing up. So I'll just be presenting some of the key findings and learnings from my research. So just as a brief background, the latest census data has shown that nearly 50% of people in Australia were born overseas or had a parent or parents who were born overseas, and nearly 1/5 speak a language other than English at home. So lots of people from very diverse cultural and language backgrounds living in Australia. And although we don't know a lot about regarding the sexual and reproductive health of these very diverse people, what we do know suggests that they often have poorer reproductive and sexual health and are less engaged with services for this. So we've done 2 literature reviews, both of which are published and the references are there. So the first one we did was a scoping review to describe the range of research that is available on this in Australia in order to identify gaps in the literature. And 2 of the kind of key gaps we found are around the perspectives of young people from migrant and refugee backgrounds on this and how they engage and are engaged with services. So that's kind of what we focused the research on. And the second literature review was published in the Handbook of Migration and Health. So the aim of the research was to explore different perspectives in order to better understand the complexities and opportunities for engaging migrant and refugee young people with sexual and reproductive health information and care. Our particular interest was in Western Sydney because it's particularly culturally diverse, but we also recruited from Sydney more generally. So we had 2 key groups. So the first was key informants. So they were service providers, policymakers, academics and community advocates. And also the second group was the young people themselves. So the research was qualitative and it involved several types of interviews with these 2 groups, which I'll get into in a sec. So the eligibility criteria, I guess, for the young people was quite broad. So they were 16 to 24 years, living in Sydney, identifying themselves as being from a migrant or refugee background and speaking another language other than English. So with the key informants, we just did 1 semi-structured interview with them. And then with the young people, we did 3 rounds of interviews. So the first was a semi-structured first interview with all of them. And then with a subset of those, we did some repeat or follow-up interviews to follow up from their first interview. And we also did some walking interviews, which was essentially a tour of different health services. So I walked around with the individual young person, and they provided feedback on the service and their observations. Yeah, it was really great. The reflections on the service, really. We also put together a youth advisory group. They kind of fed into the early stages of the research, and towards the end, we recruited them just through our own networks. So they were young people over the age of 18 who were happy to participate. The main challenge with that, in addition to just finding them in the first place, was in meeting. So the first few times we actually met over a private Facebook group, which worked reasonably well. And then we met face-to-face more recently to go through the findings from the research. So they fed into the design at the start, and then towards the end, I presented some of the key findings, and they provided their observations and their thoughts on those. So these were the services that partnered with the research. So they're listed there, and some of them are pictured there. So they supported the research in a few different ways. They helped with the design. They helped with ethics approval. They helped with recruitment primarily. They're really helpful with recruitment. And I will be presenting some of the key findings to them for their feedback as well, but haven't done that just yet. And they also supported the walking interviews. So these are the services that I did the walking interviews through. So one of the bigger hurdles was getting ethics approval. So we had to get ethics approval from quite a few different committees. We got UNSW approval first, so that we could get started with the key informant interviews while we were getting the other ethics approval. We had to get Western Sydney LHD approval, and then once we had that, we got all the site-specific approvals for the different services. And we also got family planning and ACON approval to recruit through their services as well. They had lots of feedback, as I'm sure you can imagine, but I've just pulled out kind of three of their main concerns. The first was around they wanted us to get parental consent for anyone under the age of 18, but we were able to, I guess, successfully argue that that would be a barrier for participation for young people. And we were able to give some examples of other research that involved young people that didn't need parental consent, and so they were happy for us to recruit from 16 onwards without parental consent, which was good. They weren't comfortable with us using incentives, so we were going to offer incentives for participation, but they weren't happy with that. So in the end, they said that they would be happy for us to provide a travel reimbursement for the young people who participated, which worked quite well in the end, I think. And there was lots of queries around involving young people from refugee backgrounds. They raised questions around whether it would affect these young people's visas if they participated, if it was even appropriate to include them in the first place, whether we had to involve the Department of Immigration. So it was really helpful. One of our partners was the Refugee Health Service, so they were able to help us respond to that and kind of reassure the committee that those weren't relevant in this particular research. So after a lot of toing and froing, we did get ethics approval, and in the end, we did 34 interviews with key informants, and we did 27 interviews with migrant and refugee young people. So we did the first round of 27 interviews, and then we also did 10 repeat interviews with a subset of the first group, and then we did 15 walking interviews through the different health services. So some young people participated in just one walking interview, some participated in a few different ones. So I'm focusing mainly today on the findings from young people, but I've just thought I'd share a few things about the key informants as well. So this is just the professional background of the key informants. The majority were from New South Wales, though there were a small few from other states in Australia as well. So I'm just presenting two main findings from them. So the first was around appreciating the complexities of cultural diversity. So most of the key informants kind of grappled with how to conceptualise cultural diversity and define it. A lot of them felt that using the term culturally and linguistically diverse, or COLD, which is a popular term in policy and services, risked collapsing these young people into a homogenous group. But there were different feelings about this. Some people thought it wasn't an appropriate term, and they didn't think it was a term that anybody could identify with, which is reflected in this quote. So one academic said, "COLD is a category that pretty much nobody I know identifies with. It's often referred to incorrectly as a community, as in the COLD community, but there is no COLD community. And it's a category that kind of covers over more than it reveals." But then on the other hand to that, others recognised that we have to use something, or they felt we had to use something, and they thought that this was the least problematic term. So for this research, we've actually been using the term migrant refugee young people. The second was around recognising structural barriers to engagement. So there are a few barriers that were identified by the key informants. The first was around the fact that many health services focus on particular diseases or particular priority populations, which they felt presented a barrier and could limit access to these services. They also mentioned the challenges that young people, particularly migrant and refugee young people, can experience in accessing health services. So many of them expressed that if a young person doesn't know about services or don't know where to go or don't know what to expect, then they're not going to go to the service, which also came out a lot in the interviews with young people, which I'll go into. And lastly, a further concern to the informants was just the lack of a national sexual and reproductive health policy. So several raised concerns around the absence of a national policy and also the different mix between federal and state responsibilities in this area. Sorry, I'm just going to quickly pour water because I'm getting croaky. So these are the characteristics of the young people. So there are a few more female participants than male. And this is based on a short demographic questionnaire that young people filled in themselves after their first interview. I should also note all of the participants spoke English. We did actually submit an ethics amendment to be able to include non-English speaking young people, which would have been great, and we did get approval for that, but all of the participants did speak English. So I'm going to present 4 key findings from the interviews with young people, and I'll go through these now. So the first was around overcoming the silence on sexual and reproductive health. So the vast majority of participants really emphasised that this is something that they can't discuss or they don't discuss with their parents around sex, sexuality, sexual health. It was off limits for most of the young people. So I've just put up a few quotes, and these are pseudonyms that the young people chose for themselves as well. So James said, "It's like no man's land. We don't speak of it. No one speaks of it." Julia said, they would have my head if I mentioned anything to do with like sex or anything. And that was in relation to her parents. And the last one, it's just one of those things that we don't even deal with. Nearly all mentioned school as their first source of information growing up. Most had attended at least a few years of high school in Australia, and most had had some form of relationships and sexuality education. The majority of them did find it actually quite useful. They said it was beneficial. It informed them. It was the first place they learned about a lot of these issues, and it helped prepare them for the future, and they were able to remember what they learned at school. So David said, "I still use that knowledge today. I've remembered it. What I learned in school was enough for then, and it was basically getting you ready for the future. It stuck with me." However, some limitations to it were noted, particularly that it was outdated and very brief for a lot of the young people. Most of them did get some education, but for a lot of them it was just kind of a one-off session. A number of other sources were raised, the internet in particular. I think all of them mentioned the internet as a key source of information for them. They felt that it had the answers that they wanted, and quite a number of them mentioned that it was anonymous, which was very important to them. They did recognise some limitations, particularly around the quality of some of the information on the internet, but also that they sometimes read horror stories, as they put it, or more negative reviews about things. But despite that, all of them use the internet frequently, particularly Google. So Liz says Google is life. And David said it's all anonymity on the internet. They did, in addition to Google, that was the one that came up mostly, but they did mention watching YouTube clips around sexual health. Several of them had joined private closed Facebook groups, and Reddit was also mentioned. Most of them did speak to friends, not all friends, but kind of a select group of trustworthy friends. So they were comfortable speaking to their friends if they trusted that they wouldn't speak to others about what they were talking about. But there was also mention that they wanted their friends to have the same level of experience as them, to be able to talk to them. And also several noted that they needed to be from a different cultural background. They weren't comfortable talking to people from the same cultural background. Nearly all mentioned health professionals as a source of information, but not one that they necessarily used. Health professionals were generally seen as trusted, though less so if they were from the same cultural background as the young person, and or if they were a family doctor. So if they'd kind of been going to that doctor since they were a child, and or if their parents also went to the same doctor. So although all of them mentioned health professionals, they also said that they'd use the internet and or speak to a friend first before going to see a doctor. So Anzu says, I'd start with a friend and then internet, and then when I work up the courage properly, like a professional. 4 of the young people were from a recent refugee background, and 2 of those 4 mentioned intensive English centres as one of the ways they had learned about sexual health in Australia. And they thought that was really valuable. They thought, yeah, that was really great. And a small number of male participants mentioned pornography as a way that themselves and their friends had learned about sex growing up. So the second finding was around both experience and perceived judgment from older people. So nearly all of the interviews, participants, community members and service providers were commonly positioned as generationally distinctive in interviews and old or older. Older people were generally perceived to be judgmental, less knowledgeable, and less open and accepting. There wasn't really a consensus on what makes someone old. I got lots of different responses, but it was generally someone in their late 30s and 40s and beyond. So Mimi says it's almost normal for older people to maybe judge, people for their choices because it's maybe a different generation. And Denise says if they were the same age as my parents, they'd probably be judging me. So there was a very strong preference for a younger clinician, and they were perceived to be less judgmental and also more knowledgeable than older clinicians. So that came out in quite a lot of the interviews around preferences for a younger clinician. So Mimi says, I feel like with younger doctors, they're less judgmental than older doctors. The reception staff are old. It might be better to have more young people so young people feel comfortable to come. And Panda says, I felt embarrassed because it's a male, he's old, he's on the olden days, so he's judging me. And there was a preference, not as strong a preference, but a preference by many for a female clinician for sexual health issues, and that was both by male and female participants. So making sense of sexual and reproductive health. So despite most of the participants saying that they had received some form of sex education at school and that they were able to access information through the internet or other sources, many of them also stated that an issue for both themselves and their friends was limited knowledge around sexual and reproductive health, and they had varied understanding of different issues. They had mixed knowledge of things like contraception and STIs, and some misinformation on different topics. So I've just included some examples here. So Liz said the thought of the condom getting stuck in there and then going to the hospital and then your mum coming there. Mimi says, I thought cervical cancer wasn't necessary because my family don't have a history of cancer. And Panda said, other than the normal, what's it called, the normal checks you have, you check yourself, you have a flu, it's not lasted for 6 months, so you're okay. People say if you get a flu and it heals before 6 months, then you're okay, you don't have AIDS. And this also came out quite strongly that they just don't know where to go, even if they wanted to go somewhere for help. They're not familiar with services that they can go to besides the GP. And they said that not knowing where to go for contraception or for STI testing is an issue for them and young people generally. And this is something that wasn't included in any of the sex education they got at school in terms of what services they could go to. So just some of the quotes. I think the mega thing is knowing what that is and actually knowing like which one's a problem, which one isn't a problem, which one to ask for help, which one you shouldn't ask for help, and where to go. And James said, no, they didn't talk about this stuff at school. I didn't really know about these clinics until now. It wasn't until this year because I realised that you can Google this stuff. And Sarah said, I didn't actually know that services like this existed. And that's in relation to services like sexual health and family planning services, and youth health services, sorry. Which brings me to the last finding I'll present today, which is in relation to learning how to navigate the health system for sexual and reproductive health. So as I said, the vast majority of young people were completely unaware of the different services available for sexual and reproductive health, apart from the GP, which most were familiar with, and none had learned about this at school at all. Most of them were extremely reluctant to go to a family doctor for sexual and reproductive health concerns. That was for a few reasons. One was confidentiality. They were worried that the doctor would tell their parents about their visit or other people in the community. They were also embarrassed. Often the family doctor was one they'd gone to from when they were quite young. So although they had a good relationship with them, they didn't want to talk to them about sexual health. And the third one was around judgment. They were worried about being judged by the doctor. So there was a real reluctance to go to the family doctor for these things. So James said, I wasn't too keen on going to my family doctor. It's like the absolute last resort. And Denise said, my parents use the same GP. He might just slip up. And many had also had less positive experiences with GPs. So those that had a family doctor generally had a good relationship with them, even though they weren't comfortable talking to them about sexual health. But others who'd been to other GPs generally didn't have great experiences with them. So Kath says, I feel like they don't care. All they do is prescribe you, give you, and tell you to pick it up. And Mary said, sorry, this one's quite long. I kind of feel like there's not really, should I say rude or something? I don't know, they're kind of like not much friendly. So a lot of them had they felt like they were rushed through, that the GP hadn't listened to their concerns, or they didn't get what they wanted out of the consult. They'd just been prescribed something and moved on. So although participants had a fairly low awareness of the different services available for sexual and reproductive health, like sexual health and family planning services, they did have a sense that they were an appealing option. They said that they thought they'd be more knowledgeable about these things and they wouldn't be judgmental because it was normal for them. And just some of the quotes. So Liz said, I would go there because they deal with things like that. I'm not the first person in there, so I'm not special. And Amir said, if I know there's a sexual health clinic, I'd prefer to go there, but I have no idea where it is. And Apple said, I would go to a more specialist one because they're used to that every single day. It's like basically their job. And interestingly, despite the silence and stigma around this topic, which came out in all of the interviews, none of the young people identified that as a barrier for actually going to family planning and sexual health services. So just to conclude, it was very apparent from the interviews that these young people from extremely diverse backgrounds were more similar than different when talking about sexual health. They didn't think of themselves as particularly unique or different. They described themselves as a young person, being from the younger generation, rather than as people from particular cultures or different backgrounds. It was also very clear that school-based relationships and sexuality education is really important for this group who may otherwise not learn about these things at home. And that could also be, that education could be included in other settings like universities and intensive English centres and TAFEs. And that could also be a really important entry point to increase awareness of different services available and enhance confidence in using those. And lastly, I think there's an opportunity here for more specialised services like sexual health services and family planning services and youth health services to prioritise migrant and refugee young people as an alternative to the family doctor and GPs. That's it. Thank you. So the question is around the rationale for using the walking interviews as a method. Yeah. So we wanted to include that we're really interested in young people's views of different services, particularly for sexual and reproductive health. So we thought that the walking interview would be a good way to get specific feedback on different features of services that they like or dislike. I'm not familiar with the study that you mentioned. I thought it was extremely valuable. It helped to build rapport with the young person. It was a less formal setting than the typical interview setting. Those who did more than one got obviously quite a lot more comfortable as we did more than one, so they weren't quite sure what to expect for the first one. But then as we did more, they kind of noticed more things and were a bit more chattier, and so it was a really good way to, I guess, delve deeper into their insights and reflections on different services. So I thought it was quite valuable, particularly because we were interested in how services work with this group of young people, so it was great to get the feedback from young people themselves.
There's some ethical, well, a number of ethical concerns. One of them is the aim of the study is not to identify or evaluate specific services. So, but the services are really interested in knowing how young people are experiencing walking through those spaces and how they want to make sense, particularly where they felt welcome and not. So knowing how to feed back so that in a way that's not identifiable particular services. But it's certainly one of the motivations of services in partnering at this kind of research.
Yeah, so more on the walking. I've got some questions about the practicality of it. So have young people been to these services before, or were they new to the service?
They were, so the question was around whether the young people had been to the service for the walking interview. So none of them had. I did walking interviews at all services except if they were recruited from a particular service. We didn't do the walking interview at that service.
And what kind of experience of the service did they have? Was it literally just looking at the physical structure and using types of range, or did they have the interaction and stuff? And then how did they record this data with you? Was there a private space you went to?
Yeah. So the experience of doing the walking interview, it was more physical. There wasn't much interaction. One of the ethics requirements was that they didn't want the walking interviews to be done during when clinics were open, I think for confidentiality reasons. so there was, during some of them, there was staff around, but there wasn't clients, and it was quite separate. So there might have been staff in the background, but there wasn't kind of any interaction as part of the interview. And in terms of how we recorded it, so if there was no one around, if the clinic was closed, essentially, we kind of chatted, and I took notes as we walked through. So we kind of start from the complete outside on the street almost, and then came in and walked our way through, pointed out different features. We also looked at the websites and other things. So if there was no one around, I could take notes, and we just kind of slowly meander through and chatting and taking notes. If it was a bit busier, so if there was clinicians around or staff at reception, we'd still do the exact same thing, but then we'd go into a private clinic room after, and that's when I'd not ask questions. It was very informal, but I did have some prompts about types of the rooms and features, and that's when I'd write my notes. Good question. I don't know how to go back here. So I'll just bring up the characteristics again, just so you can see, because that was one of the questions on the demographic. So we asked about sexual identity and sexual attraction, and this was their responses. So there were quite a mix of sexual identities, I guess. That didn't come out a lot in terms of how they accessed services specifically, and I haven't looked at that group specifically in the sample to see if what the findings are like for them, but certainly for young people who were same-sex attracted or weren't sure, there was a lot of concern around coming out to their parents or talking to their parents, and most of them hadn't. So it was something that they hadn't spoken to their parents or family about, and often not their friends. So that was, that did come up quite a bit and was certainly an issue for them.
So this notion of walking toward quite
Mm-hmm.
So I'd be really interested in how it's not just the visual impact or civil and how that extends capacity for intimacy or welcoming. And also how the interviewers sort of reflected as well. But also the other question I thought was around, to me, the kind of tension or the contradiction between there's not much awareness or there's a poor awareness of the existing, but yet they would still want to go to services.
Yeah.
Was it because they sort of knew that these services existed in general, but just couldn't access them?
So answer your second question first around how they had a sense about the services. So most of them did have, a general idea that these services might exist. There were a few comments that they knew they needed a referral to go to these type of services, or they knew they were very expensive, so they wouldn't be able to go. That was just a small few. And we talked about what services are available, and they weren't aware of any and couldn't name any. But then when we were talking about would you be comfortable going to a service like this, they said yes. I know that they wouldn't be judgmental, or so it was I agree. There is that tension that and the first question around the getting a sense of the service while doing the walking interview. So they did, in terms of the services being welcoming, just as one example you gave, I think they really did get a sense of that. Although the service wasn't functioning with kind of clients and people around, a lot of the feedback was around whether they felt the service was welcoming or not, and that's things that they brought up. So even things like having posters on the walls and colourful walls, and a lot of them talked about liking bright, colourful things that made them feel comfortable. They also talked about liking seeing young people, whether that's on a poster or at reception. They thought that felt welcoming, being able to see other young people at the service. So although we didn't get a sense of the service as it was running, they could still, I think, see whether they would feel comfortable going there or not. Yeah. Yeah, so we'd go through the different rooms, and I was familiar with all of the services, so I would just basically take them through like you would a client, like go to reception or whatever, and then have a look around the waiting room, see what's in the waiting room, walk through the hallways, look at the clinic rooms.
I know that there was one comment about one of the people flying to sexual health through Google, but those recruited through a sexual clinic, how do they know that?
Yeah, so about approximately half of the participants were recruited through a service, and the other half through word of mouth or other ways, essentially word of mouth. So those who were recruited through a health service, all of them had found out through Google or through a friend. So if a friend had recommended they go to that service, or they'd Googled kind of contraception in their suburb. Good question. That's hard to, I mean, I felt that it was important. They all had a lot to say about it, but having said that, they also knew that that was what the interview was about. So it's hard to say whether that's why they participated, because it is something that they're interested in. So I'm not sure. I don't know if Christy, you've got...
They all talked about it as, well, maybe not all, but it was a big part. So sexuality was a big part of their lives, and part of how they talked about being different from all people. So their sense of, and yeah, the definition of
I just scraped in.
which mattered in terms of that, how the
I think that was really good.
But so the way that you talk, all of the discussion around the things I can't talk about, the things I don't know, the things, in terms of services or parents and so on, there was never a sense that meant I'm limited in my sexual life. But, like I'm still I'm going to, or I am engaging in sexual activity, variety of kinds, variety of experience levels, depending on age and different things. But the kind of challenges around that were more about how do I make sense of, or how does that interface with the world more broadly? So older people, services, schools, so on. Yeah. Does that make sense? Sexual health, though, as opposed to sexuality, I think there was some fears and a misunderstanding, wanting to know, but yeah, no, it wasn't like the major priority.
Yeah.
Okay, I think we should wrap up.